Next, Dr. Soumya, Pythium keratitis, battling the dreaded pathogen.
Good morning, one and all. I'm Dr. Soumya Vegesna, Cornea Fellow from Visionary Eye Hospital, Vizag. Today I'm going to present you about the Pythium keratitis, battling the dreaded pathogen. So, my topic covers the scope like background, study, description and results, and conclusion. So, background. Pythium insidoism is an oomyosite and is closely called parafungus as it closely mimics fungal keratitis. So, the classical clinical features of Pythium that distinguish it from other microorganisms are reticular dots, tentacular projections, peripheral furrowing, early limbal spread, which require a high incidence of clinical suspicion. The picture A is showing a central dense infiltrate with tentacle-like projections extending to the periphery, and picture B and C show a dense white infiltrate with multiple dot-like para-infiltrates extending from the main infiltrate, and also there is peripheral furrowing from 2 o'clock to 4 o'clock position, along with a hypopion of about 1 mm in size. Smear and culture. The slide A shows the culture plate of Pythium insidoism, and also Pythium exhibits morphological and microbiological resemblance to fungus on routine smearing, revealing perpendicular or obtuse septate or aseptate branching hyphae. And also in slide C, we can see the septate or branching hyphae which is resembling the fungal keratitis. So my study design is case series, and the purpose of my study is to elucidate the clinical presentation, management and complications of Pythium keratitis. Methods. 2 cases of Pythium keratitis were included in my study after microbiological evaluation, detailed slit lamp examination, corneal scrapings and microbiological evaluation. So the results of my study, this is a case 1, a 40-year-old male presented to our OPD with history of fall of dust in the right eye, and he complained of redness in the right eye along with severe pain, watering and discharge. So first is the initial presentation with a central dense white infiltrate of about 5 into 5 mm in size with tentacle-like projections extending to the periphery. Despite giving maximum medical and maximum medical treatment and systemic therapy, there is no improvement in the condition of the infiltrate. So we went to for therapeutic penetrating keratoplasty, and this was a picture of post-operative day 1 keratoplasty. Initial presentation, the vision was only HM hand movements positive with no improvement with pinhole, and after post-operative 2 weeks the infiltrate was almost decreased, and also cornea is relatively clear with best corrected visual acuity improved to 6/9 parts. This is the case 2, a 45-year-old male presented with history of injury with stick 10 days back, and he also presented with same complaints of severe pain, redness and watering in the right eye. And also there was infiltrate with about 6 into 6 mm infiltrate with peripheral furrowing and gutte-like appearance along with hypopion of about 1 mm in size. In spite giving maximal medical therapy and also systemic therapy, there was no improvement in the condition of infiltrate. So we went to therapeutic penetrating keratoplasty, and this is a picture of post-operative day 1, and also the post-operative 2 months picture showed relative decrease in the infiltrate and also relatively clear cornea, and the vision improved to 6/12. So both the cases had favorable clinical outcomes in eliminating the infection from the eye. So conclusion, when a diagnosis of Pythium keratitis is made and maximum medical therapy is given, and if they do not respond in 2 weeks time, we should not hesitate in going ahead with therapeutic keratoplasty, as delay in this critical intervention can weigh against the favorable outcomes. These are my references. Thank you.
How did you know it is Pythium? The
So
question
based
is
on
because clinically when you see it looks more like a fungal, what I mean.
Yes,
so it's
sir.
very difficult to get cases.
Yes, sir.
Understand?
Based on the morphology, sir, there's more dense infiltrate with peripheral gutterous presence.
Most of the bacterial, fungal and all this are most different. Even crystalline keratopathy you
But in spite giving maximal fungal treatment for about 1 week or 2 weeks with topical antibiotics and also topical antifungals and systemic antifungals, there was no improvement. So we went.
Start on linezolid and other azithromycin.
Yes, so we
also.
started on linezolid, azithromycin, and voriconazole, natamate, and doxycycline, but there was no improvement.
So you did the scraping by sending, or your button you had sent for the.
No, so we did the local scraping, and then we didn't send the button for the culture.
Are there any other studies similar to yours?
There are a couple of studies, ma'am. Even they show even the final intervention was therapeutic penetrating keratoplasty in those studies also.
Thank you, Dr.